to maintain nutrition than to replenish body stores from malnutrition. The effect of starvation on the body, even during relatively brief period, is well documented. The small amount of glycogen stored in the liver is a crucial immediate energy store. Glycogen breakdown for fuel begins 2 to 3 hours after a meal, and glycogen stores are depleted after 30 hours of fasting in the absence of metabolic stress. Release of amino acids from body tissues begins after 4 to 6 hours of fasting to provide a source of blood glucose. Fatty acids are mobilized from the body's adipose tissues to provide keto acids as a principal fuel for heart, brain, and other vital organs. As adaptation to starving occurs, the body relies less on amino acids from protein for fuel and uses more ketones from fat to meet metabolic needs. This reduces the nitrogen losses and preserves the lean body mass. During critical illness, this adaptation to insufficient energy to meet needs does not occur. Severely ill patients rely heavily on large amounts of glucose and proteins for fuel. They often have elevated insulin levels, which inhibit the mobilization of fat for energy production and increase reliance on amino acids from protein with a urinary nitrogen losses of 10 to 15 grams per day. Critical illness can lead to severe depletion of lean body mass. Nutrition provides during critical illness reduces the but does not reserve the process. Management of nutrition support is performed by an officially nutrition support committee or team composed of designated members from the departments of medicine, nutrition, surgery, and pharmacy. Each team member should be certified in nutrition support by an accreditation body such as National Board of Nutrition Support Certification and the Board of Pharmaceutical Specialists. Nutrition data obtained before starting nutrition support provide a means of measuring effectiveness of treatment at designated periods during the therapy. Certain tests are repeated to monitor the patient's course and reduce the metabolic complications. Specific protocols vary in different medical centers. Primary importance to the three major monitoring parameters include serial weights to determine the adequacy of total energy provision and to monitor the fluid status. Physical examination for micronutrient adequacy and changes in body fat and muscle mass, and improvements in functional status. All baselines and monitoring data are recorded in the patient's chart along with the enteral and parenteral solution orders. Determination of when to initiate nutrition support depends on the patient's nutritional status and the anticipated time period before oral diet can be resumed and tolerated. Nutrition support should be considered when the patient has had an inadequate oral intake for 7 to 14 days or the patient's oral intake is anticipated to remain inadequate for 10 to 14 days. A 5 to 10 day timeline is recommended for critically ill patients. Other guidelines available to identify when to feed are the rule of 5 and amount of weight loss. The rule of 5 states that if a patient has had no food for 5 days and is unable to tolerate an oral diet for an additional 5 days, nutrition support should be considered to reduce the risk of developing malnutrition. The weight loss rule stratifies patients according to the percentage of weight loss of their usual body weight over a designated period. Patients who have undergone severe weight loss and are unable to tolerate oral nutrition for 5 to 7 days or longer are candidates for nutritional support. What is the main difference between enteral nutrition and the parenteral nutrition? The most appropriate enteral tube feeding formulas according to each patient's specific disease state. What is the preferred method of formula delivery? And which factors contribute to internal tube feeding related complications such as diarrhea and respiratory problems? In all cases, when the GIT tract is functioning, enteral nutrition supports should be used to restore or maintain an optimal state of nutrition. Parenteral nutrition should be reserved for patients with a non-functional GIT tract or an inadequately functional GIT tract that prevents the patients from meeting nutrient needs entirely. In some cases, the patient can take some enteral feeding, but impairment in either digestive or absorptive capacity requires supplementation with parenteral therapy. Pre-operative nutrition support will be beneficial for severely malnourished patients, but contribution to increased complications in mild to moderate malnourished patients. The GI tract should always be the first choice for nutrition support. Parenteral nutrition is associated with serious complication. Reliance on parenteral nutrition when the GI tract is functional can contribute to GIT tract with subsequent bacterial overgrowth, hepatic abnormalities, deterioration of GI integrity, with subsequent migration of intestinal bacteria into the systematic circulation, and sepsis. Patients reliant solely on parenteral nutrition are at risk for septic and hepatic complications that can contribute to morbidity and mortality. The GIT tract is the body's largest immune organ. GI disease that prevents or reduces the use of the GIT functions may itself contribute to adverse effects often associated with parenteral nutrition. It may not be the root of aging, but rather the inability to use the gut that increases infectious and metabolic complications. Some adverse effect of parenteral nutrition may be related to inability to provide all necessary nutrients parenterally. Parenteral solutions are not as complete, for that maybe they do not contain the wide variety of nutrients as enteral formulas or an oral diet because of the complexity of adding all the nutrients found in nature to an intravenous solution. Many patients with a functioning GIT tract do not or cannot eat a sufficient amount of nutrients by mouth to restore, repair, or maintain physiologic systems or body tissues. The first option for providing the adequate nutrition should be deliver nutrients orally. The patients can be given small, frequent, nutrient dense meals with an oral liquid nutritional supplements. If oral intake remains suboptimal despite attempts to increase nutrients intake with nutritional supplement and diet changes, then enteral tube feeding can be initiated to meet nutrient and energy requirement. If it is not feasible to use the GIT track for feeding, or if the GIT track cannot effectively provide consistent and adequate nutrition, then parenteral nutrition may be an appropriate feeding modality. Some questions remain unanswered during this nutrition, which will include the patients require nutrition support or not. What is the optimal route of feeding, oral, tube feeding, or parenteral? Will the enteral route alone be sufficient to meet nutrient and energy requirement? What type of formula is needed and how should it be provided? Does the patient require long-term nutrition support? When a patient does not consume a nutritionally complete diet, the energy value of foods in the oral diet can be increased according to the patient's tolerance and preferences with added seasoning and dressings. Frequent, less bulky, concentrated small meals may be helpful so that the patient is not overwhelmed or discouraged by a tray full of food. If a patient is on a modified diet, for example, a low fat diet, low sodium diet, or diabetic diet, then liberalization of the diet as much as is medically feasible can help improve oral intakes. For example, changing from a 1800 kilocalorie diabetic diet to a carbohydrate counting diet allows the patient more flexibility in food selection. It may be necessary to liberalize to an unrestricted or regular diet to increase oral intake, depending on the patient's condition and food preferences. An oral liquid nutritional supplement, commercially available, either made in houses, can be provided with or between the meals. Taste fatigue can happen fairly rapidly when patients are receiving 2 to 6 cans of an oral nutritional supplements per day. Patients may use their nutritional supplements as meal replacements, not increasing overall energy and nutrient intake. It is important to offer nutritional supplements in a variety of flavors and textures to maintain adequate consumption. Some facilities, particularly those specializing in long term care, have found that dispensing oral nutritional supplements in small amounts of 30 to 60 ml during times when medications are administered improved oral nutritional supplements intake and nutrient delivery. Small bone nasogastric tube feeding, generally from 8 to 12 French, made of softer, more flexible polyurethane and silicone material, have placed former large bone stiff tubing. Small bore feeding tubes are more comfortable for patients and permit the infusion of commercially available enteral tube feeding formulas. Nasoenteric tubes can be inserted into either the stomach or beyond the pyloric valve into the small intestine. Distal placement of a feeding tube beyond the ligament of into the jejunum is often preferred for the patient with a history or risk of aspiration, impaired gastric emptying, depressed reflux, neurologic impairment, and critical illness. Feeding tube insertion can be done blindly at the bedside or using the radiographic visualization. Placements of a feeding tube should be performed by experienced, trained personnel. Feeding tube placement is an invasive procedure and carries the risk of misplacement into the lungs or brain, as well as perforation of the GI tract. During the placement, aspirants of GI content can be checked for pH and enzyme concentration, as well as visually inspected to reduce the number of radiographs required to determine when the desired location has been reached. No tube feeding should be infused until feeding tube placement is confirmed by the radiography. Nasoenteric tube placement is usually indicated for short-term therapy. For enteral feeding anticipated to last more than 3 to 4 weeks, surgically or endoscopically placed enterostomies are preferred. A cervical esophagostomy can be placed at the level of the cervical spine to the side of the neck after head and neck surgeries for cancer or traumatic injury. This removes the discomfort of a nasoenteric tube and the entry point can be concealed under the clothing. In the gastrostomy, a gastrostomy tube is surgically or endoscopically placed in the stomach if the patient is not at risk for aspiration and has normal gastric motility. In jujustomy, tube is surgically or endoscopically placed past the ligament of the jejunum, the middle section of the small intestine. This procedure is indicated for the patient with neurologic impairment, a risk or history of aspiration, and incompetent gag reflex, or gastric dysfunction. Gastric dysfunction can be related to the gastric atony, gastroparesis, gastric cancer, gastric outlet obstructions, or gastric ulcerative diseases. Enteral tube feeding should be flushed routinely with water to maintain patency and prevent the clogging. Tap water is generally sufficient. If concerns exist regarding the safety of the water source, if the patient is immunosuppressed, the sterile water may be used to flush the feeding tube. Standard flushing volumes are 30 ml of the water every 4 hours during continuous feeding. Water flushes for intermittent and bolus internal feedings are a minimum of 30 ml immediately after each feeding. The amount of water flushed through the tube is adjusted according to the patient's fluid requirement and tolerance. Large fluid volumes will be needed for patients who cannot drink water for hydration. Smaller fluid volumes are needed for the patients on fluid restrictions. Prior to the availability of commercial enteral formulas, the first enteral formula were created by blenderized regular diets and using broth or gravy to thin the mixture enough to flow through feeding tubes. Today, the majority of enteral tube feedings in healthcare facilities are given with the defined commercial prepared enteral tube feeding formulas. Financial or personal reasons may motivate a patient or family to use blenderized formulas for home enteral tube feeding. Although emotional comfort may be achieved by using home prepared food, its use does create the problem. These problems involve its physical form, which could cause tube clogging, an increased risk of bacterial contamination, and inconsistent nutrient adequacy based on the foods chosen and preparation techniques used. The blenderized formulas must be given into the stomach and requires a normal GIT tract to digest and absorb the nutrients contained in the formula. In contrast to homemade enteral formulas, commercial enteral tube feeding formulas provide sterile, nutritionally complete, homogenized solutions suitable for small bore enteral feeding tubes. Enteral tube feedings formulas are available as polymeric, semi-elemental, or oligomeric, and elemental or monomeric formulas. It is important to keep the abreast of products currently available because new formulations and enteral tube feeding products are constantly being developed. Polymeric enteral tube feeding formulas require digestion and are available with and without fiber. Macronutrients and micronutrients of a polymeric tube feeding formulas can be modified for specific needs of patient with various disease states. Semi-elemental or oligomeric tube feeding formulas are partially digested or hydrolyzed. Smaller molecule increase the osmolality of the formula. Elemental or monomeric tube feeding formulas are completely pre-digested and require only absorption for assimilation into the body. These formulas have the highest osmolality, lowest viscosity, and worst taste of all enteral tube feeding formulas. Elemental or monomeric tube feeding formulas are completely pre-digested and require only absorption for assimilation into the body. These formulas have the highest osmolality, lowest viscosity, and worst taste of all enteral tube feeding formulas. Enteral tube feeding formulas will also vary according to the nutrient density from 1 to 2 kilocalorie per ml. More concentrated formulas are designed for patients with fluid intolerance, such as those with renal, hepatic, or cardiac failure, as well as for the patients who desire less volume or fewer feeding per day. If patients who receive a concentrated enteral tube feeding formulas do not have fluid restrictions, it is imperative to provide adequate water so that they do not become dehydrated. Are the nutrient components of these enteral feedings? Approximately 50 to 60% of the energy comes from carbohydrate, starches, and sugars. Carbohydrates are the body's primary energy source. Although large starch molecules are well tolerated and easily digested by the most patients, their relative insolubility creates problem in enteral tube feeding formulas. Smaller sugars formed by partial or complete breakdown of cornstarch and other glucose polymers are common tube feeding formulas component. Very few enteral tube feeding formulas contain lactose because lactose intolerance is common among hospitalized patients. Tube feeding formulas can also contain soluble and insoluble fibers. Considerable controversy exists as to be the benefit of providing fiber in enteral tube feeding formulation. Insoluble fiber increases stool volume, and is used to treat problems with gastric motility such as constipation or diarrhea. Soluble fiber has been promoted to improve blood sugar, reduce serum cholesterol levels, and maintain the colon health. The focus on maintaining the normal intestinal bacteria has resulted in increased research and availability of prebiotics and probiotics given with or in enteral tube feeding formulas. Prebiotics, non digestible food components, provide fuel to enhance the repletion of normal bacteria found in the GIT tract, whereas probiotics, live non pathogenic microbes, are designed to repopulate it by providing good bacteria directly to the GIT tract. The strain of probiotic and combinations of strains most effective depends on the therapeutic intent. Protein content of standard enteral tube feeding formulas is designed to maintain body cell mass and promote the tissue synthesis and repair. Biologic quality of dietary proteins depends on its amino acid profile, especially its relative proportions of essential amino acid. To supply these needs, three major forms of proteins are used in nutrition support enteral tube feeding formulas, which include intact proteins, hydrolyzed proteins, and crystalline amino acids. In the intact proteins, these are the complete and original forms as found in foods, although protein isolates such as lactalbumin and casein from milk are intact proteins that have been separated from their original food sources. These larger polypeptides and proteins must be broken down further before they can be absorbed. In hydrolyzed proteins, the protein sources that have been broken down by the enzymes into smaller protein fragments in amino acid. These smaller products are tripeptides, dipeptides, and free amino acid are absorbed more readily into the blood circulation. In the crystalline amino acid, pure crystalline amino acids are readily absorbed, particularly when combined in a mix of dipeptides and tripeptides. The small size of the amino acids results in an increase in osmolality of the formula. Amino acid result in a bitter tasting formulas. If an elemental tube feeding formula is used as an oral supplement, then it requires flavoring aids or special preparation method to improve taste. For example, pudding and slush. Despite flavoring, the taste can still be unexpected to a sick patient or can quickly lead to taste fatigue and refusal by the patients. The major role of fat is an enteral tube feeding formulas are to supply a concentrated energy sources, essential fatty acid, and a transport mechanism for fat soluble vitamins. Major forms of fat used in standard formulas are butterfat in milk, based mixtures, vegetable oils from corn, soy, safflower or sunflower, medium chain triglycerides, and lecithin. Vegetable oils supply a rich source of the essential fatty acid, which is the linoleic acid and linolenic acid. Standard whole diet Commercial tube feeding formulas provide 100% of the recommended dietary allowances and dietary reference intake for the vitamins and minerals when the formula is provided at a specific volume per day. The volume required to provide the RDA and DIR varies with each tube feeding formulas and the nutrient requirement of the patient. Delivery of a reduced volume and use of diluted formulas may require supplementation with vitamin and mineral preparations. Patients with nutrient deficiencies may require supplementation of specific vitamins and minerals in addition to the standard vitamin and minerals composition of the enteral tube feeding formulas. Several enteral tube feeding formulas are designed for specific patients' population and contain the micronutrient designed to meet the requirements of the particular disease state or condition. Certain tube feeding formulas designed for the special nutrition therapy are called medical food. Medical food as distinct from drugs in 1972 when the first special formula was developed for the treatment of the genetic disease phenylketonuria in the newborns. The definition of medical food remained rather murky as medical research developed an increasing number of special formulas. An explosion of specially enteral tube feeding formulas has occurred over the past 10 years. Several products are available in each category of disease or condition specific formulation that include end stage renal disease, hepatic disease, pulmonary disease, diabetes mellitus, malabsorption syndrome, immunoincompetence, oncology, and metabolic stress. Every patient with one of the diagnoses does not need a specially tube feeding formulas. Indications for specialty tube feeding formulas are limited to a small subset of the patients within each disease state, classification for which a specialty formulas is designed. Commercially available, nutritionally complete enteral formulas product for tube feeding are designed with a fixed ratio of nutrients to meet journal standards for nutritional needs. Some patients' particular needs are not met by these standard fixed ratio tube feeding formulas, and they require an individualized modular formula. An individual formula composed completely of modular components is planned, calculated, prepared, and administered with the expertise of the RD. Modular enteral components, the more common use of addition of carbohydrates, fats, or proteins to a commercial formula to individualize the calorie and protein content of the formula for the patient. For example, additional protein powder can be added to increase the amount of protein per liter, or more carbohydrate or fat can be added to increase the energy concentration. Other modulator nutrients such as fiber and probiotic or prebiotics can also be added to the feeding rhyme but should be given separately through the feeding tube and not added directly to the commercially tube feeding. Every component added to an enteral tube feeding formula can increase the osmolality and viscosity of the formula and contribute to feeding intolerance. bacterial contamination, or clogging of the feeding tube. Blue food dye is often added to tube feeding formulas to detect aspirations of the formula into the trachea and lungs. Concern exists as to the safety, speciality, and sensitivity of the blue dye in identifying the aspiration in tube-fed patients. The addition of blue food dye increases risk of the bacterial contamination, false positive occurred stool test, discoloration of the skin and body fluids, and death. No standardization exists for how much food dye to add per liter of tube feeding formulas, with formula hues ranging from pale to cobalt blue. Methylene blue should not be added to tube feeding formulas because it can adversely affect cellular functions. Colored dyes are not diagnostic for the aspirations, are potentially harmful, and should not be added to tube feeding. Non-recumbent positioning is an evidence-based method for aspiration prevention and should be emphasized in all tube-fed patients. Monitoring of the tube-fed patient should focus on transitioning to an oral diet and reducing or eliminating the dependency on tube feeding. All patients being nourished by tube feeding should be carefully monitored for signs and symptoms of enteral tube feeding intolerance. Tolerance to enteral tube feeding is determined by GI signs of vomiting, abdominal distension or bloating, and frequency and consistency of bowel movement. If problem occur, then the tube feeding formula may need to be replaced, the infusion rate adjusted, or the method of administration changed until tolerance improves and symptoms subside. In most incidents, the tube feeding formula itself is not the causative agent for the intolerance. Residual volume and diarrhea are two parameters that are often used to determine tolerance to tube feeding. Both are terms that have no standardized definition within each institution, much less nationwide standard definitions. Diarrhea is generally defined by the person cleaning it up and can be based on volume, frequency, or consistency of the stool. Each healthcare facility should define diarrhea and then create an algorithm or protocol for treatment to reduce unnecessary interpretations of enteral feeding. The interpretation of residual volume is also often determined by the caregiver's experience and not evidence-based guidelines. Enteral feeds are interpreted for the gastric residual volumes ranging from 50 to 200 ml. GI aspirations that contain the gastric enzymes and hydrochloric acid required for digestion, electrolyte, enteral formulas, and fluid should be returned to the patient after determining the volume. If doing so would make the patient uncomfortable, or if the volume removed exceed 300 ml, then the residuals should be discarded and rechecked in 1 to 2 hours. The feeding tube should be flushed with 30 ml water after checking and returning residue to be sure gastric contents with the digestive enzymes are no longer within the lumen of the feeding tubes. The patient tolerance of the tube feeding formulas, state of hydration, and nutritional response to the tube feeding should be monitored using the data collected from feeding should be monitored using the data response to tube feeding should be monitored using the data collected from a variety of sources, including laboratory, anthropometric, physical and clinical assessment, and nursing records. Protocols for enteral tube feeding can provide the guidelines for troubleshooting problems and improve the nutrient delivery. Blood glucose level should be monitored daily or more frequently in the patient who have diabetes or are at risk for diabetes. It is important not to overfeed the patients on nutrition support. Insulin has been provided as needed to maintain serum glucose level at less than 200 mg per dl. A growing body of evidence indicate that glycemic control between 110 mg per dl and 140 mg per dl can significantly reduce the mortality and morbidity in ICU patients. Daily weights compared with the baseline weight before start of the tube feeding along with daily input and output measures are essential for an accurate assessment of the patient's tolerance and nutrient adequacy. Routine monitoring also includes serum test for potassium, sodium, chloride, carbon dioxide, creatinine, as well as BUN and complete blood count, along with periodic test for urine specific gravity. Signs of volume deficit or dehydration include weight loss, poor skin, dry mucous membrane, and low blood pressure from decreased blood volume. Patient also demonstrate increased serum level of sodium, albumin, hematocrit, as well as elevated urine specific gravity levels. Severe dehydration is critical and life threatening. Fluid requirements can be estimated by several available formulas, such as 1 ml of water per kilocalorie or 30 to 35 ml per kg. Water content of the enteral tube feeding formula and the amount of the water given with medications and routine flushing of the feeding tube, as well as the patient's medical condition, are taken into consideration when determining the patient's fluid requirement. Fluid must be monitored for adequacy and adjusted as necessary to attain and maintain adequate dehydration. Signs of volume excess or overhydration include weight gain, edema, distension, elevated blood pressure, and decreased serum level of sodium, albumin, and hematocrit. Patient with renal, cardiac, and hepatic impairment may require less fluid than other patients. The patient medical record is an essential means of communication among the members of the healthcare team. The healthcare team is involved in actions and documentation related to all ongoing nutritional analysis of actual tube feeding formula intake, tolerance of the formula, and any complications, desired versus actual outcomes, recommendations for the adjustments in tube feeding formulas, routine tube flushing and method and rate of delivery, and education of the patient and family.